Brain is a small little active organ. It only occupies about 2% of a body weight. It is metabolically very active because every time we think, the brain is really working, and for every little action we do, the brain has to function. What exactly is this stroke is? There is a lot of misconception about the stroke per se. Stroke, some people say I had a stroke, and then when we ask them, they would come back and say that they've suffered a heart attack. It's not the same. It is the attack of the brain. Whenever there is a lack of blood supply and this blood supply affects part of the brain or a whole of the brain, it is a type of stroke. There is also another type of stroke where there is bleeding in the brain. And I want to popularize the term brain attack. You're all familiar with heart attack, where there is lack of blood supply to the heart and the heart suffers. Likewise, any lack of blood supply to the brain or bleeding inside and outside the brain is called a brain attack. We as Indians have a higher risk of stroke because of high incidence of diabetes and hypertension. When somebody suffers a stroke, there is a lot of disturbance in the whole family. That is, it is a big social burden. Imagine somebody having a stroke in the family. They get treatment in the hospital, they come back home with a disability. Not only the income for the patient is lost, but also the caregiver's income is lost. The caregiver has to spend time with the patient to take care of the patient properly, and the whole family is struggling, and it becomes a big social burden. We have to be aware of what are the early signs of stroke, how to get proper treatment, so this kind of disability in the community, disability in the family is reduced or prevented. Let's see some of the problems that can possibly potentially cause a stroke. Most common cause that can cause a brain attack is actually the heart problems. When the heart rhythm is not good, the heart produces clots, and these clots can fly into the brain and can block a blood vessel and can cause a stroke. Or some people with the problems in the blood per se. The blood may have hypercoagulability, that is, the blood has a tendency to form clots, and when these form clots, these clots can go in and block blood vessels. It may be a small clot causing stroke in a small part of the brain, or maybe a big chunk of clot blocking the major blood vessels of the brain. Sometimes the blood vessel problems. Some people have what is called an aneurysm, a bubble in the blood vessel wall, which usually is not symptomatic till it ruptures and bleeds. So these are things are more common in people who have high blood pressure. So high blood pressure has to be taken care of. And some people have arteriovenous malformation, some abnormal tangle of vessels in the brain that can cause bleeding inside the brain. High blood pressure alone, without any of these, aneurysm or AVM, you can develop a bleed. That is a hypertensive intracerebral hemorrhage, we call it. And it is one of the common causes of stroke. And it usually happens though in old age, and because of the changing lifestyle, it is becoming more common in younger and younger people. The other problems that can potentially cause a stroke are diabetes, stress, work stress, or change in the lifestyle related stress, financial stress. All this can put you at a higher risk of developing a stroke. And very rarely, some people are genetically prone to develop stroke. So if a family member has developed a stroke, other family members at a beyond certain age group needs to be tested for the risk of stroke. Okay, let's see what really is the sign of stroke. How will you pick up somebody having a stroke? Unlike the heart attack, when somebody is developing a chest pain, it is a very painful condition and you need an ECG to check. But here in stroke, it is a painless condition. Some people are not able to use their hands. Some people are not able to talk to you properly. When you talk to them, they're not able to understand what you're talking. These are the signs of stroke. People have to be aware that these things are signs of stroke, and they have to take them right into the hospital to be treated properly. Because if you leave time, the brain cells die and the patient may not recover, and it leads to disability. Let me just tell you the common signs of stroke. Okay. The most common one is not able to lift the hand properly. If you ask them to lift the hand will be sagging down. And then you ask them to give a smile. Smile, their face will be deviating on one side. You talk to them, they are not able to understand what you're talking, and they will not be able to reply back to you. These are the signs of stroke. Some people, you ask them to stand, their balance will be lacking, they may be drifting to one side. Some patients may have deviation of the eyes and they will not be able to look to one side. These are all the common signs of stroke. So when I talk to patients and families about signs of stroke, I tell them if you ought to check for somebody having a stroke, all you need to do is ask them to stand. If they're able to stand, it's good. Then ask them to lift both their hands. If they're able to lift their hand and hold it like that, that's good. If the hand is drifting, that's a sign of stroke. Ask them to give a smile. If they're able to smile with equal movement of the face on both sides, that's good. If not, it's a sign of stroke. And ask them to speak a sentence. If they are able to understand what you're asking and if they are replying back, for example, asking them, what's your name? Or what did you have for breakfast? These are simple questions which anybody will answer. So these things you ask them to reply, and if they are able to tell properly, then we are good. If they are not able to tell, if they are mumbling and if they are searching for words, then it's a sign of stroke. And when somebody has a stroke, when you take them to the hospital, the most important thing you have to note down is the time of onset, because that helps us a lot in treating the patient. Okay, if somebody developed a stroke while waking up, like early in the morning, that's a very common scenario. Nobody would have noticed like when they actually develop stroke. We take the time of onset of stroke as last seen normal. That is the previous night when they went to bed, that is considered the time of onset of stroke. Or somebody sitting in the office, that's also a common scenario. Oh, 10 minutes back I saw him in the cafeteria, he was fine and he was talking to us, and all of a sudden he was found on the desk. That 10 minutes back, that is the time we take as the onset of stroke. Why? Why is this important? It's because when a patient comes to the hospital, our treatment is designed based on the time. Every minute that passes after the onset of stroke, about 2 million neurons are dying. So the more the time passes, the lesser the chance of recovery. The lesser the time, the higher the chance of recovery. So the time of onset is extremely, extremely important. The other important factor, you have picked up somebody with a stroke, the next thing you should do is take them to a well-equipped hospital which has all the facilities. Okay, going to a smaller nursing home does not help the patient because the emergency care is not very streamlined, and for example, they may not have a CT scan or an MRI scan in the hospital. The patient has to be sent to a nearest center, which takes time, and for the reports to come, it takes time. And every minute that is lost, brain is lost. You should remember. So a well-equipped hospital is the one which is stroke ready, which has 24/7 neurologist, which has a neurointerventional services, which has inbuilt CT scan, MRIs, and all the facilities in-house. Is a stroke ready hospital which can provide you a complete care of the stroke, because here time is of essence and time is extremely, extremely important. So you get into the hospital, the way it is set up is that the patient is suspected to have a stroke. The patient is immediately taken to the CT room where imaging is done. Okay, if needed, an additional imaging is done right away, and the treatment is decided right after 5 minutes after the scan is done, and the treatment is initiated. This kind of a system is extremely important, and the time you arrive at the hospital to the time the treatment is started should be less than 30 minutes. That is the standard we have, and that is what we should be able to provide to each of the patient coming to the hospital with a stroke. What are the imaging we do? Generally, when somebody comes with a stroke, if the patient has signs of a stroke, then he is moved to a CT scan room first. We do a plain CT scan. If the CT scan shows a bleed, then the way we look at it is completely different. Okay, if somebody has a stroke which is due to blockage of the blood vessel, that is called ischemic stroke, the treatment is completely different. So there the pathway is divided. Then we do what is called a CT angiogram, that is looking at the blood vessels of the brain, the complex blood vessels of the brain, by injecting little dye into your vein, and then we image with the CT scan. That gives us an information about whether there is any abnormal bubble in the blood vessel wall or if there is a block in the blood vessel. All these are picked up, and our treatment is decided right after that. Okay, and there are also some advanced imaging. For example, some patient comes to the hospital beyond say 6 hours of onset of the stroke, then we do some additional imaging. Because any patient coming within the first 6 hours, our treatment is designed in a streamlined fashion to treat them with IV thrombolytics. If they have a large vessel occlusion, we treat them with intravenous thrombolytics. If they have small vessel occlusion as well, we treat them with intravenous thrombolytics. And if they have a large vessel occlusion and they don't recover with intravenous drug treatment, Then the next step we do is we go in the cath lab, and then we go inside the blood vessel, and then we put in small stent retriever kind of an object to pull the clot out, or we suck the clot out to recanalize the blood vessel. This is for the ischemic stroke. If the patient has a hemorrhagic stroke, then we decide about whether the patient needs an external ventricular drain, and then we do an angiogram to check how the aneurysm looks, and then we treat it either with coiling or open surgery and clipping. For patients who are coming beyond 6 hours of onset, that is, for example, you have a stroke at 2 o'clock in the afternoon, and then they hit multiple hospitals, they come to us by about, say, beyond 8 o'clock at night, then that is 6 hours of time has already lapsed. So in these patients, not every part of the brain is intact. Some part of the brain might have already died. So in these patients, our imaging is different. We do additional imaging called CT perfusion scan or MRI perfusion scan to pick up which of these patients will really benefit with our treatment. And there are some subset of patients who may not benefit, and we don't offer treatment for them. But there is a good number of patients who will be benefited, and these patients, we select them and we offer them treatment. Whereas patients with the bleed, even if they come beyond 6 hours, the treatment doesn't differ much, but we offer treatment for everybody with the bleed. Okay. Patients coming early with an acute ischemic stroke, 4.5 hours, we give IV thrombolytics, and beyond 4.5 hours, it is called endovascular mechanical thrombectomy. It is a treatment that we offer, wherein we go in through the blood vessels of the leg, the groin blood vessels. We put a small little plastic tubes called catheters. These catheters go all the way up to the neck. We inject dye to check the blood vessels of the brain, and we will find out the block, and where there is a block, we will go inside with the device to take the clot out, and we offer recanalization. For patients who had bleed, for example, if there is an aneurysm, we go through the same route. We go in and then we seal off the blood vessel which is leaking. That is, we seal it off from inside. It is called endovascular coiling, and that is a very common procedure that we do, and that will seal off the blood vessel to prevent it from bleeding again. In today's scenario, somebody presenting with an acute ischemic stroke, let's say, who has got a block in the blood vessel going to the brain, we will be able to recanalize in about 80 to 90% of the time. But do all these patients recover? Yes, good number of them recover to a good functional level. I would say about 60% of the patients that we recanalize get back to their normal routine life with no disability or with very minimal disability, and a good number of them get back to their office, get back to their work, get back to their routine life. The point to note here is that when they get back to their routine life is that they are not disabled, they are not a burden to themselves, they are not a burden to the family or the society. This is what I want all of you to understand. This is extremely important to get them into the hospital on time so that this kind of treatment can be offered and they can get back to their routine, normal life without any disability. That is what we hope for in each of the patients. There are some unlucky ones, but most of them, we can get them back on feet and get them back to their routine life. And all of you should understand the fact that we live in today's world in a very stressful situation. That is, in the COVID era, it is stressful for everybody. Other emergencies do happen apart from COVID. Other emergencies like heart ailments, brain ailments like stroke do happen in these era. And when these ailments happen, get to the hospital immediately. Do not simply stay at home fearing that hospital is a hotspot where you can get COVID. COVID is a less of a problem. More than COVID, people suffer from other disease, and these people need to be treated. We at Apollo Hospitals are geared up for it. We have separate pathways for COVID patients and we have separate pathway for non-COVID patients, and we treat every emergency on merit when they come to the hospital, and we treat them in a timely fashion without any interruption of service. We as specialists are always available to treat these patients and get them back on feet. And I end my session by telling you that brain attack is treatable and time is brain. The more the time wasted, the more the disability. So earlier they come to the hospital, the faster recovery that one would achieve. Thank you.